Thank you so much. It's so nice to be here. What a wonderful community and foundation this is, and I'm sure it means a lot to all the patients to have this kind of a resource, and very educated community who may know more about chordomas than I do, so we'll talk together, but also nice to follow Dr. Desai and work with the wonderful surgeons and whole chordoma team here, which is really important. So my name is Hiniker. I'm an associate professor in radiation oncology at Stanford. I treat the pediatric patients primarily and some adult CNS and other tumors as well. And I'm one of the co-directors of our new Proton Center, which we are planning to treat the first patients in December of this year. So coming along well. Okay, and so in terms of chordoma, as everyone here knows very well, it can occur in multiple parts of the body, skull base, the mobile spine, the sacrum. And when we look at the NCCN guidelines for treatment of this tumor, we see clearly that surgery is a very important part of this. Radiation is used when needed in the context of surgery, or if surgery can't be done, definitive radiation is something that can be done on its own, but we do think patients have the best outcome when surgery is a part of the care. And then as radiation oncologists, how do we optimally incorporate our treatment, radiation, into this treatment? I think, as you'll hear from many people, the most important thing is having a multidisciplinary team that works well together and tries to coordinate everything as best as possible, because these tumors can be challenging to manage. They're relatively radio-resistant. They don't shrink away easily with radiation. So surgery is important, but they also do often occur in these locations where a wide resection is very difficult or sometimes impossible. So radiation can be used in a number of ways. Can be used after surgery if needed to address microscopic residual disease. Before surgery, so-called neoadjuvant, in order to potentially facilitate surgery and reduce a risk of recurrence. It can be used both before and after surgery. As I said, sometimes without surgery as a definitive local control strategy. And then also, if patients have recurrent disease or metastatic disease, radiation can be an important part of taking care of those aspects. So for radiation considerations, these are often slow-growing tumors and don't shrink quickly to radiation. Radiation mostly works through DNA damage, and we typically use it as fractionated over a number of weeks in order to take advantage of the different repair capabilities of tumor cells versus normal tissue. The traditional radiation therapy approaches used in the past with sort of a standard postoperative fractionated dose with photon therapy have been somewhat disappointing in terms of the local control rates they provide. And so what we've seen over recent years and what we're continuing to see in the research in this area is that these more advanced radiation therapy techniques are likely important for treatment of chordoma, including particle therapy, with proton therapy showing benefits, new developments in carbon ion therapy, and also stereotactic techniques using stereotactic radiosurgery. At Stanford, we use CyberKnife at times, or fractionated stereotactic radiation therapy, which is similar technique, but spread out over a number of weeks. In terms of the importance of surgery, this is just a study showing the importance of wide margins when they can be accomplished. And this was a study done without radiation, so looking at outcomes of patients with a spine chordoma after resection. The patients who were able to have a wide margin resection in the red line did extremely well, and none of them recurred. But patients who could not have a wide margin resection and had more of an intralesional excision mostly had recurrence. So really the adequacy of the margins is very important, but also given the location where these tumors arise, can be very difficult to achieve. However, with the radiation therapy planning and delivery, it's also complicated because these tumors occur in areas where they're right next to critical adjacent organs that can't tolerate too much radiation. So they may occur in the base of the skull, next to the brainstem, in the spine next to the spinal cord or in the sacrum, next to the sacral nerve roots. And given that this entity is not the most radiosensitive and requires a high dose, these technical challenges of radiation are really important for us to consider. This shows a comparison of 3 different radiation techniques. On the far right, this IMRT plan uses photon therapy as sort of more traditional, what we use for most tumors. But you can see in the dose distribution, and really this red line that you see on every slide is where you would like to be targeting. And you would like to not get much dose to the middle, which is the spinal cord. And you would like to not get much dose out here to the bowel and the other abdominal organs. You can see that the IMRT plan has kind of this gradual dose fall off, where you are getting more dose to the normal organs that you would like not to. And you can see even in the center, where the spinal cord is, it's getting a higher dose than what you would like. In the middle, we have proton therapy. One main benefit is this lower dose, more steeper fall off, so you're getting essentially no dose to these abdominal organs here. And you can see in the center, with that blue area, the spinal cord's getting a lower dose. So you can cover your target better while minimizing dose to the organs you like to avoid. And then on this far left, this is actually carbon radiotherapy plan, which has the same kind of nice dose sparing as the proton plan, and may also provide the ability to increase dose to the target while sparing normal tissues. So for something like chordoma, these advanced techniques are really important when we're walking that fine line between needing a very high dose for tumor control in chordoma and being right next to these important critical structures. So over time, we've seen these advances in technology to better treat chordoma using radiation, and this sort of moves along. It's not an exact line of improvement, but kind of from the 2D era where we used to treat patients just with X-ray, basically point and shoot, and you sort of got what you got, and the normal tissues make it almost as much as the chordoma. Then over time, moving to 3D, where things are planned on a CT scan, to IMRT, which is a photon plan, which can lower normal doses somewhat, to probably a big advance for this particular disease with protons, and then also radiosurgery, which can be used for some targets. Not every target is appropriate, but this can also give a nice high dose. What I'll tell you about today in terms of the developments of upright proton therapy, which is what we'll be doing at Stanford, and the ability for proton arc therapy, which can give some very beautiful plans. Carbon ions, which are just starting to become available in the United States with the first facility in Jacksonville. And then for the future, what we're building on now with this flash radiation therapy, which treats tumors extremely quickly and seems to have even better normal tissue effects. So progress is certainly being made. General treatment paradigms, how we think about this in our department, and in radiation oncology in general. And I put as a little picture of Dr. Scott Soltis there, who is wonderful, and I think he's really our lead chordoma expert, and I'm sure he'll get to talk to you at some point, but he's kind of a thought leader who we all go to with these types of questions. But how we often think about things is skull base surgery, post-op radiation, and then spine. If it's fully resected, potentially no radiation. How we have started to move here at Stanford and other places, some do and some don't in terms of the timing of radiation, is to do part of the radiation preoperatively, then the surgery, and then complete the radiation postoperatively, depending on extent of resection. And at Stanford, in terms of trying to increase the dose using more advanced technologies, we've used the preoperative SRS or radiosurgery techniques when possible, and continuing on with a part of it postoperatively as well. Just to look at a couple of radiation plans, this was a patient actually from the literature treated using a proton plan after a gross total resection of a clival chordoma, and you can see in panels A and B, the initial tumor extent, and then B is after the resection, where there was only postoperative changes left, the radiation plan, which shows using protons, nice coverage of this target, and then brainstem, which is our most critical organ in this area, being nicely spared and not getting the high dose area. So that's much more possible using protons, and then the follow-up MRI looking very nice and clean. Our general dose constraints that are used, the brainstem and the optic structures really kind of limit the dose that can be used in this area, so that's can be benefit of protons. And then a patient treated using CyberKnife as the preoperative extent of tumor, and then with a boost to the gross tumor, you can see that the benefits of the radiosurgery are also to give that kind of steep dose gradient. We're limited in terms of how large a target we can treat with radiosurgery, but this one was appropriate for it, and another patient of Dr. Soltis. Certainly think, as radiation oncologists, half of what we do is treating patients palliatively. So patients who have recurrent disease or metastatic disease, and that's true in general, not necessarily chordoma, but radiation is very useful for symptoms when someone has a recurrent or metastatic disease and can be treated in a short number of fractions. And that's can be true for chordoma and other patients, that radiation is very valuable in those settings as well. In terms of this proton and photon question, and thinking about it, at Stanford, and I'll show on the map in a minute, in the Bay Area, we have not been ever, nearby to protons. It's more than a 4-hour drive in any direction. And so when we do think that protons are potentially important for a particular patient, we tend to refer them out to a trusted center, or colleague at a trusted center, to ask them to deliver proton therapy. And in some situations, we don't know if protons are better. For example, in the literature, I'd say that to this point, we don't really have any studies for prostate cancer that show that proton therapy is better. That's not true in chordoma. I think we have seen multiple studies that these advanced radiation techniques seem to be associated with a better survival in patients with chordoma. This is an NCDB survival analysis, so it uses big claims data. You don't get the details exactly of the patient case, so there certainly will be a lot of confounders when you group people together, and there will be differences of the patients who have the ability to travel for protons versus those who are in a tougher situation and really maybe need treatment to start really quickly and they're sicker. And so the patients are going to be different groups, but we do keep seeing in repeated studies that there are real benefits that appear in for patients who can be treated with proton therapy that are compelling. And so at Stanford, we've wanted protons for a while, but they can be very difficult to access in terms of expense and really the land and the size of the infrastructure that's been required. And so, 50 years probably we've wanted protons and it has never quite happened. And this is a report from just last year that was published looking at the access to proton therapy around the United States. And you can see in the red, we are in these proton therapy deserts where we're at least 4.5 hours from the closest proton facility. And so the Bay Area really we've had to send patients out who need protons. And that has been true largely because of the infrastructure and the expense required, the construction, the lack of land. And this shows a typical proton therapy facility and what this requires. So in terms of the gantry, that's shown kind of opened up under construction on the right, that's typically like 2 to 3 stories tall. It's a huge building that's the size of a football field frequently. And so requires a lot of expense, a lot of land, and the finances, which I'm not an expert on, but it can be difficult to build back the revenue. Apparently, when you build something like this, the volume of patients apparently that you would need to support it can be very large, and so maybe people try to treat patients with protons who it might not always be necessary just due to financial concerns. So it's been very complicated until recently. So what we're developing at Stanford and is being installed currently, and I put Dr. Bill Liu, who's the co-director of the Proton Center, and really this was partly his brainchild, is how can we do proton therapy in a more compact way, and to make it smaller and to fit into a kind of standard linear accelerator vault. So this actually is being installed and will be within our department in one of our normal treatment area rooms that's just been expanded just a little bit. And so it's different. The concept is essentially that the gantry, this huge, large area, the reason why it would require a football field and multiple floors was that this huge machine had to rotate while the beam was on to deliver the appropriate plan for the patient. The concept of this ultra-compact proton therapy is that it's a fixed beam line, so the beam line doesn't move, and therefore it can fit into a fairly standard-sized room. The patient is semi-upright, so it's a semi-seated position, and the patient will slowly rotate while the treatment is ongoing. So because of these technical aspects, the patient is slowly moving while the beam is on to deliver the plan, but this can be done in a much, much smaller scale to still allow for proton therapy and the beautiful plan that you want, but without requiring this massive infrastructure. So Stanford will be the first institution in the world to have this technology, and others are joining as well, but we will be treating the first patients. And actually Stanford has a long history of upright positioning, even back with LA1 and our first patients. I think the first patient treated at Stanford many, many decades ago was a little child with retinoblastoma, and he was treated sitting up. So this actually is sort of a kind of back to the future, or taking some lessons from our history in terms of patients being treated upright in the past as well. And what this leads to with this ability too is development potential for proton arc therapy. So this combines the kind of best technologies that we've had so far in terms of the arc therapy using the IMRT approach, but also now using photons. And so the proton arc therapy is outlined in red there, and you can see the dose fall off is just better than either that other proton plan or the VMAT plan. That final slide, or that final figure, is showing the difference, sort of the subtraction of what are we sparing when we're using this proton arc therapy. So this technology lends itself to that very well as well. And so yeah, a main thing that we're excited about is this will be directly within our department. This is the layout of where this is. It was our old LA15 area that's being built out. Currently under construction, but coming along well. And this was an older picture of when they're actually putting the cyclotron in. So a whole new concept we're excited about, and one thing that we're especially excited about in its development is providing the kind of proof of concept and the initial data for this. And if this works at this price point, which is probably 5 times less than, or 20% maybe of a normal proton cost, and with the space considerations, then it becomes something where protons become more of a real possibility globally, and in countries with less access to care. This is something that's much more doable. In terms of the proton therapy, we're working with the LEO team who developed the chair, and figuring out various aspects of this, such as patients distracting children in the upright position, figuring out anesthesia concepts. Patients can be treated either in a forward-leaning position. When they do need craniospinal, there are other aspects that will be considered in terms of immobilization, and then figuring out for the children how to best do this. So there's many aspects we're considering. It's an exciting time to be part of it, but we're really happy that we will be having the ability to use protons at Stanford, and specifically for chordoma. I think that will be something that we can be ready to treat early on in terms of the head and neck, and then also potentially the pelvic treatments. So just some aspects more of the pediatric side of things. And we're fortunate to work with our physicists here who've come up with a number of creative solutions to different situations, including upright therapy. Just finally, a couple of words on the newest technologies, including carbon ion therapy. The first U.S. center will be, we believe, in Mayo Jacksonville, and that's under construction now. And this is using carbon ions, so a particle therapy, but different than protons, and appears to potentially have the same benefits of the spared low-dose areas from the radiation that we see with protons, and potentially can increase the dose and give even of a more focused plan. And then finally, the latest technology is under development. Something we'll be working on at Stanford is using flash therapy and flash arc therapy. And that is essentially delivering the radiation therapy using a technology that's extremely fast and delivering it in seconds as opposed to minutes with our current radiation techniques. When this can be done, the early data shows significantly lower risk of side effects to the normal structures. So much preclinical and early clinical data is ongoing, but particularly for these tumors that can be tricky to treat and requiring higher doses but have critical adjacent normal structures, this is really exciting for the future. So finally, just in summary, as everyone here knows well, the treatment of chordoma is very complex, and a strong multidisciplinary team with a lot of experience is important. We think that radiation is an important part in conjunction with surgery to help better control disease, but also learning more about finding ways to reduce the effects on surrounding normal tissue, and particle therapy, including protons, are already well established as being important in the treatment course. And then a lot of newer technologies, including using upright protons and the flash therapy, are very exciting for further making a difference in this disease. So thank you all for listening, and I wanted to acknowledge my collaborators, and certainly our chordoma specialists and CNS specialists, and proton co-director and our chair. And thank you so much, and I'm happy to take questions later on with